Hi, everybody. I'd like to welcome you to this month's virtual support group. My name is Jillian Schultz. I'm the program director for the Parkinson Association of the Carolinas, and I'm excited for this month's group, or topic, which I know can be a little bit taboo or difficult to talk about for some people, but I think it's something that's very important. And I'm glad that we're able to address it. I heard that it was canceled last year. We were going to do this support group last year topic, but we had to cancel it. I don't know what the reason was, so I was glad to be able to bring it back this year. So Melissa Wirtz is a occupational therapist at Duke University Health, and she provides care across several of Duke's specialty clinics, including the ALS Clinic, Parkinson's Disease Clinic, and Huntington's Disease Clinic. And I'm going to turn it over to her to lead our presentation. Welcome.
Thank you. Thank you so much for having me, everybody. I'm going to share my screen with you. All right. Okay. Can you see that okay?
It's still coming up. There we go.
It's good.
Yes.
Okay, wonderful. Again, thank you for having me. I'm Melissa, I'm an occupational therapist from Duke. I've been practicing for 12 years now. And like Jillian said, in our outpatient clinics, and I am very excited to be here to talk with you about this topic. So we are going to talk about sex and intimacy and Parkinson's disease from an occupational therapy perspective because I'm an occupational therapist. And so I know this can feel like an uncomfortable topic, but it's also very normal and an important part of life. So my goal for this presentation is not to tell anyone what they should be doing, but really just to open up the conversation, normalize any challenges that you may be having, and hopefully offer some practical solutions as well. So I always like to start my presentations sort of talking about what occupational therapy is, because a lot of people have either never heard of occupational therapy, think we're just basically physical therapy, but I want to kind of delve a little bit more into what occupational therapy is and why I feel like somebody that is an expert at talking about this topic. So occupational therapy is all about helping people stay independent and engaged in meaningful activities. So when Parkinson's affects movement, energy, mood, or confidence, it can also affect intimacy. And so, excuse me, intimacy is a meaningful occupation, just like anything else you do in your day, like getting yourself dressed, or grooming, or cooking, showering, really anything you do in your day. Intimacy is just as important and as just as an important, meaningful activity than those other things as well. So, if Parkinson's disease is impacting this part of life, it definitely deserves attention and support. And that's why an occupational therapist is qualified to talk about this subject. So we know that there are motor symptoms and non-motor symptoms of Parkinson's, and both of the motor and the non-motor symptoms can influence intimacy. So things like stiffness or tremor, balance changes, fatigue, pain, or slow thinking can make activities more challenging. Additionally, things like medications or changes in autonomic um, function can also play a role in some of these disruptions that may impact intimacy. So I say all this because understanding the why can sometimes be helpful when helping us problem solve or making sure there's no blame on anybody or on partners, because these are real symptoms of Parkinson's that may be impacting someone's ability for intimacy. So this is sort of the why behind what I'm going to be talking about today. So intimacy is not just about sex. It includes emotional closeness, touch, connection, and feeling valued. So maintaining intimacy supports a lot of things. It supports our mental health, it supports our relationships, and ultimately our overall quality of life. So unfortunately, chronic illness, when somebody has a chronic illness, it doesn't eliminate the need for closeness or having intimacy. It's still very important, if not even more important. And that's why we're going to be talking about this today. Okay, so some of the challenges, like I mentioned, may be physical, emotional, or relational. Also, some of the challenges in Parkinson's and intimacy also might be role changes. So not only the role change of the person with Parkinson's, but also the role change of caregivers, changing that caregiver dynamic. And then, of course, stress can affect how partners are able to connect as well. So it's very common for couples to avoid the topic because they don't want to upset each other. Again, it is sort of seen as a somewhat taboo or uncomfortable topic at times, but avoidance can create distance, even when both partners want connection. So again, these are sort of the whys, and I'm going to continue to talk about how OT can help. All right, so OTs look at how an activity is done, not just whether it's possible. So an occupational therapist would help modify activities to support safety, comfort, and participation. And this can include either positioning strategies, recommendations on how to conserve energy, adaptive tools or adaptive solutions, and alternative communication strategies as well. So we also address emotional and interpersonal factors as well, not just physical ones. So again, just verifying how occupational therapy is well qualified to discuss this topic. All right, so before we move on to some strategies and adaptations, I want to talk about intimacy and open communication because it is a really important, if not one of the most important tools couples can have. So this could mean talking about any needs that you may have or your caregiver has, talking about fears or expectations without judgment. So the without judgment part is really important. It's okay to schedule time to talk because really these things these conversations might not just come up naturally. And so having a specific intention on having these conversations can be helpful. Care partners also need space to share their experience and feelings. Balancing caregiving and partnership takes intention because again, with those changes in roles and relationships, there are different strategies that can help bring more intention to being able to balance those things, those two different roles. Okay, so strategies for enhancing intimacy. I want to talk about a few things. So mindfulness and relaxation can help reduce tension and symptoms. There's actually a lot of research out there on the impact and use of mindfulness strategies on helping one, manage Parkinson's symptoms in general. So not only can it manage some of the physical symptoms of Parkinson's, so tremor, that sort of thing, but it also can help with a lot of the non-motor symptoms of Parkinson's as well. So anxiety or stress. This may include deep breathing exercises. It could include meditation or guided imagery. There's really no right answer for what mindfulness means. It's definitely an umbrella term, but what I talk a lot with my patients about is that it takes a lot of practice. Mindfulness does not just come naturally. It's actually similarly to like learning a new skill, like learning to ride a bike or learning to drive a car. You don't just wake up knowing how to do it. You have to practice it and you have to learn it. Just like Jillian's son who will be taking driver's ed, he has to practice and learn how to drive. Similarly to for mindfulness, you actually have to practice those strategies. So it may be finding somebody who you can work with on learning with those strategies. Occupational therapists often know how to work with somebody with these strategies, but also somebody like a counselor or a therapist may be an appropriate person to work on learning mindfulness strategies. Um, Another thing that is important or maybe helpful, I should say, for enhancing intimacy would be choosing time when energy is highest. and can make experiences more positive. So, if you know that you do have a time of the day where you're kind of feeling your best, that's probably going to be the best time for being able to schedule either these conversations or these mindfulness strategies or doing the things that you want to do during those sort of on times. Also, non-sexual touch, such as hugging, holding hands, cuddling, still builds closeness, and sometimes is just as important as the physical acts, to be able to build intimacy in that desire. These moments do really count. So now that we've talked some about what are the challenges that may be happening, I'm going to talk about some strategies to consider for modifying the activity. Um, so planning ahead, so similarly to what I just said, is, during your best time of day can help reduce any stress or frustration. So if you do have any medication off times, try to schedule intimacy during on times. If you know that that is a predictable time for you, trying to schedule that during your on times if you can. Um, Many people find that they feel best at certain times of the day or medication cycles. And so learning that and being able to implement that would be one strategy. Moving with intention and minimizing unnecessary transitions can help. So while also considering stretching or exercises to break up any stiffness or rigidity, can also be really helpful. Reducing distractions, using verbal cues can help connection and safety. Those are all strategies on how to adapt the activity to make it a little bit easier, and potentially more enjoyable as well. Again, intimacy is the ultimate goal here. So it doesn't always have to look the same as it did necessarily before diagnosis. And this may be, a potential strategy for modifying the activities that might look a little different, being able to recognize that. So the goal is connection, and not necessarily performance. And that can also take off some of the pressure that you may feel. So focusing on the process rather than the outcome can reduce anxiety. Another important thing is understanding limits and planning for them. So knowing kind of ahead of time, and this comes with that conversation that hopefully you're having with your partner, is that, if you feel like you have limits and you don't want to push that, having that conversation and knowing that ahead of time, again, can help ease any stress or anxiety that might be coming up. Being open to experimenting within comfort and safety, of course, and consent, can be empowering. And so that could range from a lot of different things, but practicing relaxation techniques, using massage or a warm bath prior to sex to reduce any symptoms of stress or anxiety or tremor or pain or rigidity, again, can help ease any stress or tension. And remember, practice makes perfect. So, practice and patience does matter. Again, with everybody on the same page. All right, so I want to talk about some adaptive equipment and aids that might be helpful. So adaptive tools can support comfort, positioning, and ease of movement. Vibrators or sex toys can be helpful. There's an unlimited variety of shapes, materials, and actions. So finding what's going to work for you and your partner. Again, maybe having things look a different like it look a different way than maybe it did before. But also simple things like adding pillows or supportive surfaces or fabrics that reduce friction, like satin sheets, can help ease of movement as well. So these tools are about function and comfort, but not replacing connection. So again, modifying the activity, but not trying to replace the connection that's underlying one of the most important parts of this. Some strategies for positioning that I want to talk about. Positioning that incorporates weight bearing can help compensate for tremors. So, like weight bearing through your arms or through your knees can be helpful. It can help. The right position is the one that feels the safest and easiest for you. So, that's important to maybe try different positions that require less energy. and help you move the easiest, but again, with the intention that it feels safe for you and your partner. Okay. So the next thing I want to talk about is energy conservation. So fatigue is a real symptom in Parkinson's, and resting before and after the activity can make a big difference. So again, this also goes back to trying to engage in this activity during your best time of day, being able to rest before, being able to rest after, to build energy back up is can be helpful, especially when fatigue, which is a real symptom of Parkinson's, may be impacting you or your loved one's ability to feel like they can participate fully. Changing positions or pacing activity helps conserve energy as well. And then listening to your body is important. It's all about adapting, not giving up. Okay, so again, maybe modifying the activity to be able to use the energy that you do have may look a little bit different, but using some of these strategies, I think, can help conserve energy overall. And then I wanted to talk about body image and sexual image because body image and self-confidence can change after a diagnosis of a disease like Parkinson's. Um, and so self-confidence is really, really important. It's common to grieve changes in how your body moves or feels. That's completely normal. Exploring new ways of moving and connecting can rebuild confidence, though, and that's why kind of where practice makes perfect and having this conversation with your care partner and loved one is really important. And partners can help explore this with you at a pace that feels safe. So again, this goes back to kind of managing some things that may also come along with Parkinson's or a diagnosis of Parkinson's, some of the more non-motor changes. But these are important to be able to improve intimacy overall as well if this is affecting you. Okay, so again, just to reiterate, intimacy does not require intercourse or a specific outcome. Connection, trust, and shared experience are often what matter most. So if concerns come up, you don't have to navigate them alone. Your partner, physician, occupational therapist are all resources. Other people in the community that you know and you feel safe talking with about, these are resources, but ultimately this is a very real topic and you are not alone. I think I really just want to make sure that message is loud and clear. If intimacy does feel distressing instead of supportive, that is a sign to get more support and not pushing through. Um, it's not, again, it's not giving up, it's moving forward together, um, and being able to figure out strategies that you and your care partner feel comfortable with. So I wanted to give some resources and support groups, different educational materials that may be interesting to you, um, and also just put in a plug for that referral to occupational therapy if you feel like this is an area that you want to address. Again, it falls well within our scope of practice and can be something that you can work with through with that support professional. All right. Any questions on anything?
You can put your questions in the chat or feel free to unmute and ask.
And if you don't feel comfortable, there are no silly or wrong questions, but if you don't feel comfortable sharing with everyone in the group, I'm happy to take questions privately too, if that works.
Hi, this is Elizabeth, and I would like you if you could just go back to the resources
Oh, sure.
slide one more time because I was
Oops.
taking some notes and I didn't get to the end. Thank
Yeah.
you.
Yeah, of course.
And I can send these out also after, so that you can have them to see those resources. Other questions?
Yes, my name is Mary, and I would also like a copy of all the slides that were presented, sent via email, if I could.
Yeah, I can
Thank
send
you.
those out I'll be uploading the webinar to YouTube so that you can watch it again, and I'll also send out the slides. I'll probably send a follow-up on Friday with all that information for you.
Thank you.
Yeah, you're welcome.
Melissa,
Yes.
hi. When you talked about the medication, I thought it was best to do it when I was not having the medication, rather than you're saying to have it when it's on the medication. Why did you say that?
Yeah, great question. And honestly, you know you best. So I'll start with that. But typically, when you're feeling on, meaning your medication is working the best it can to manage your symptoms, typically people feel that they can move the best, they can maybe think more clearly, they feel like they can do the things that they want to do in the best way they can. Um, However, if that's not true for you, then
Well, yeah, I was under the impression, see, the medication is a suppressant in many respects because it's trying to suppress the shaking and the tremors and such like and the disease. So I thought it was best if I've taken medication, that's going to suppress me. That's going to hold me back. So, so I thought it was better to do it when I was not on the medication prior to taking those tablets.
yeah, well, honestly, it is really personal preference. So
Oh,
if you do feel like it's you move better, oops, sorry, I just dropped my water. If you do move better off the medication, then manage it around that.
yeah, it was no case of movement. It's more the are you being relaxed? Are you relaxed for the moment?
Mm,
Because that's
mm,
the problem I think a lot of people encounter is you cannot relax at the end of the intimate moment, if you know what I mean.
hmm
That's the thing I was worrying about doing it with the medication on because I know the medication is a suppressant.
Yeah, yeah.
So thank you anyway. I have to experiment, as you say, with them on and off. I mean, I
There
like
you go.
some of your ideas. They were very good, and I appreciate that. Thank you.
Yeah, of course.
There's a question in the chat. Does Parkinson's medication interact with ED medication?
Ooh, that's a great question. That is outside of my scope of practice to answer that. What I would recommend is speaking with a pharmacist or your doctor. Sorry.
Are there other questions? Do you work with VA patients?
With
VA?
Oh, yes, I do. Um, Sometimes it requires like prior authorization, but I'm assuming Veterans Affairs is what is meant, right? Okay. Um, we do it, but it often does require prior authorization from the VA, but yes.
So I've got a question. This is Bob here.
Hi.
Um, in terms of, well, first, in terms of my personal experience, having REM sleep behavior disorder has led to the fact that I can no longer sleep with my wife because I beat up on her at night, even though I'm not conscious of that. And that has affected the, let's say, the sense of intimacy or the availability of it because I'd love to cuddle at night, but a black and blue wife is not a happy wife.
Right.
Uh,
Yeah.
so
Yeah.
So I found that to be the case, and then sometimes I have noticed a change in sexual behavior, sexual performance, and the
Mhm.
question always is, does it come from Parkinson's in any way? Does it come from being old age? Does it come from psychological effects? And what to do with all this mixture.
Yeah.
Um, I have found that it's important just to attempt with my wife to schedule a close off cuddle session
Yeah.
where necessarily, sex doesn't have to happen. It's nice if it does. Doesn't have to happen, but at least you get that closeness.
Yeah. Yeah.
So there's a lot of stuff that I find that I have to work with here, and no easy solution. There is no pill.
No, no. I think you're absolutely right. You've hit a lot of different different points and how all of those different things can impact intimacy. Um, but it sounds like you have managed by modifying some of, you've scheduled, you said the cuddling, which I think is great, but just that's a great way to build intimacy. And then again, you're right as far as like, what is the thing that might be impacting me? Is it the Parkinson's or aging or whatever? Um, that there can be more than one thing that is going on, certainly. I will say I think a lot of these strategies work sort of regardless of what the issue is necessarily, or what's causing the issue, I should say. Um, Other than maybe some, if there is like, for lack of a better term, more of a mechanical issue going on, I would certainly follow up with your physician, um, but including some of these strategies like mindfulness can help with anxiety and stress, um, and all the different strategies for kind of modifying intimacy, even if it isn't just sex, but other strategies for building closeness. So I think you're doing a lot of the right things.
Okay.
Hey, this is Charles McComas.
Hello.
Um, First time in this group. I was diagnosed 2014, and probably in advanced states right now. But one of the problems I have was balancing everything. Is that just the we really need somebody with a good background in Parkinson's disease. It's also a therapist because there's so many things that surprise me and surprise my wife all the time. It's being driven by either the medication or the Parkinson's disease. And unfortunately, or fortunately, in my case, I don't really know. The I received Parkinson's diagnosis before I met my current wife. She's
Mm,
never seen me without Parkinson's. So that's been a difficulty because her organizational habits and things like that are much different than mine are. And that's caused us some friction in the past. But I found a lot of things like are out there on the internet that I wasn't made aware of. I think it would have been really helpful if we had somebody that we could go to that really understands why I am doing different things. And I
mm,
found out like I'm doing a lot of OCD stuff. Like I'll sit
mhm,
there and sort, and I'll go into a room and even just not. I'll sit there. I used to do all electrical work on my house, and I'll sit there and I'll just at least I'm disconnecting the power. But I'd sit there for like 25 minutes and tear a whole panel out and go, why did I
mm,
even the hell do that? Why did I
mm.
do? And just all this little OCD things that you get with Parkinson's. I'm
Yeah.
also on a little pump, which I highly recommend, guys. It's a lot of times you don't have to worry about even the pills that you're taking. I've got the dopamine pump and I've been using it since about September. Anybody wants to contact me about it, I'll be happy to tell you about it. I also had the DBS surgery. So anything that comes out, I'm going to give it a whirl. And that's
Yeah. Yeah. And now do you mean like a therapist, like a mental health therapist
mental
that
health
is?
therapist. Yeah.
Yeah. Yeah.
Yeah. We need somebody like that. least up in the Raleigh area. I've not been able to find anybody that has a background. I'm the one that educates them on Parkinson's
Mm,
disease and the effects of dopamine and all other things like that.
hmm.
And I enjoy educating people. I love to teach, but I don't want to teach my therapists on how to do their jobs.
Yeah.
Yeah.
So I don't know of any specific mental health therapists with who specialize or, have extra knowledge in Parkinson's, but I do know of some potentially who work more with the senior community.
Yeah,
I
that's what I've
don't
been called to. Yeah, I got to get
So
good.
I can follow up with you with those names that I have.
That'd be
And
great.
then, if anybody does know of mental health therapists near where you live, that are specialized in Parkinson's, because they are hard to find, please let us know, because we keep a list of all these different resources all around North and South Carolina. So that depending on where you live, we can help provide you with those. So I would love to add them to our list. But I'll follow up with you, Charles,
Thank
offline
you.
after this.
Mhm.
Thank you. I have a question regarding a little bit feedback in what you said about aging. Um, I think I am in that age of aging, but also kind of wondering more about how menopause can affect, the 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 intimacy,
Hmm.
knowing that a partner is also having, uh, you know, all. I mean, the grade on Parkinson is a little bit high. How to handle? Do we have? I don't see any research on that, or I didn't hear from much about that. How to handle this?
Great question. So the question, how does menopause also impact intimacy? Is that
That's
what?
correct. Yeah,
Yeah.
that's correct.
So definitely a little bit more outside of my scope, in regards to explaining sort of the, um, why other than hormonal changes and that sort of thing. But it is definitely something menopause can affect, desire and intimacy, um, for sure, certainly. And so that is definitely an important thing to consider, especially if, either the person with Parkinson's is going through menopause or a care partner is going through menopause. It would add on certainly would add on an additional layer, of impact on intimacy in general. I think my overall recommendation would be to speak with a, provider or a physician or somebody that can kind of help navigate through the experiences and changes that somebody may be going through with menopause, and then what sort of things could be helpful in regards to managing that. I think similarly to how you would manage some of the intimacy difficulties with Parkinson's would probably also apply with menopause as well. I think these are kind of global recommendations that could help with anybody, with Parkinson's or without Parkinson's, in regards to mindfulness, if there's any stress or anxiety, um, and then sort of scheduling conversation, around just like what is going on for each partner, and how that's impacting what they're bringing to either the relationship or the intimacy, um, and then potentially modifying strategies for, how you want to engage in intimacy, whether that be starting with non-physical intimacy and then, physical intimacy. Does that
Hmm.
kind of help?
Yeah, yeah, yeah. Thank you.
Yeah.
Yeah. Melissa, once again, you highlighted a major point about fatigue, and yes, I agree. Fatigue plays a major part in Parkinson's disease. There's also an issue about sleep. Now, each time I see my physician, the topic comes about, well, I'm only getting 4 or 5 hours sleep at best. What are your recommendations regarding sleep?
Yeah, that's a great question. And also not an uncommon symptom of Parkinson's is changes in sleep. Um, if you've heard of, well, one, I certainly recommend continuing to talk with your physician about it, and seeing what they have to say. From an occupational therapy perspective, sleep is also a occupation. It's an activity of daily living, so it's also something that we address, and within our scope. But we often talk about like sleep hygiene techniques. I don't know if you've heard that term before. Sometimes if there's something going on that we could help with that, being able to manage some of the sleep hygiene things that may help improve sleep, figuring out sort of what is the issue. Is it we know Parkinson's in general can change sleep, but could it also be stress and anxiety that's impacting sleep? And if so, are there techniques that we can help with that? Um, Also, just sleep hygiene includes like trying to go to bed around the same time every day, eliminating caffeine after a certain amount of time, um, eliminating the blue light that you get in from like screens after a certain amount of time, like about an hour before bed, those sorts of things. So those would be definitely things that I would want to talk about and consider and see if any of those things could be changed and if that would help. And then if not, certainly talking with your doctor about if medication would be appropriate for sleep. Um, and then also it would be figuring out how to best use the energy that you do have, and how to conserve energy in other ways despite having lack of sleep. Are there ways that we can help modify your energy to use it the best that you can throughout the day? I'm also a big I'm a big recommender of naps during the day if you can, because it can be a great way to build energy back up. But naps are not sleeping all day, and they shouldn't impact nighttime sleep. So those would be things that I would talk through with somebody. Usually short naps are better, but can be a really helpful way to kind of build energy back up throughout the day. So those are kind of things that I would start with.
Thank you.
Yeah.
This is Mary Norman again. Can I ask a follow-on question about that?
Sure.
Okay, my husband needs the TV on most of the night, if not an hour or so, into his sleep. But like you were suggesting, do 1 hour before bed without TV and cell phone. So how can I have like a compromise with my husband?
Great question. Yeah, that's a tough habit to break. Do you think it's like the white noise that he need or like that just kind of white noise that he needs or
I'm not sure. We do have a white noise machine
uh-huh.
that we've tried just a couple of times, but it
Yeah.
just doesn't seem to do the trick for him.
Okay. Yeah. That's a tough habit to break, especially if it's been going on for a long time. Um, that was going to be my suggestion was to potentially consider a white noise machine or something that kind of replaces that noise in the background. Um, is the TV volume on and everything?
Yes, and it seems to be louder because he doesn't have his hearing aids in. So it really is a tough situation. I've even considered going to a different bedroom without the TV.
Yeah, yeah, no, totally. Yeah, I wonder about what I would potentially consider would be something different that he might be able to do would like be potentially a podcast or something he could listen to. I don't know if like he could listen to it um with I guess you can't sleep. You probably can't sleep with the um hearing aids in. Is that right?
Correct.
Okay.
Yeah.
Um, so either potentially listening to it just through his phone or something next to the bed where he's having the sound come out. I don't know if that would affect you though, but or with ear pods in would be probably hard to keep in actually, but that might be something to try if it's just at least that noise and then the light is at least off.
Hmm.
I would
Okay. Great. Thank you.
Yeah.
there are earbuds or headphones that are made specifically for sleep too that I have seen.
Okay, that's good. to know.
And while we're not affected by Parkinson's, my husband likes the television on as well. And our eventual compromise was that, and I don't know if this is the case for you, but he really needs it more for falling asleep versus staying asleep. So once we figured that out, we just started setting the timer so that it would shut off after a certain amount of time. So I'm not sure if that's an option for you, but some things you might want to try out.
Also, Mary, for you, I would say if you can't get the TV to be turned off, an eye mask to like block out anything for you. I sleep with an eye mask now and it has been life-changing. And we don't even have the TV on. I just like any light at all. I'm like, I
Yeah.
can't sleep.
Yep. And somebody else put in the chat too that there are headphones for TVs set so that only the person watching is able
Ah,
to
okay.
listen.
Yeah. Good. Good recommendations, certainly.
And they can also pipe that if you have hearing aids, they can also pipe the sound directly to your hearing aids with
Yeah.
different kinds of adapters and everything like that. Mary, were you the one asking about the VA? Because I've been trying to get my claim approved with those guys forever.
Yes, I am currently with the VA as as a veteran, and yes, I usually have to get a referral for anybody outside the VA community, but they have to be with the VA community program or something to get
Mm.
Hmm.
it. So, right.
Okay. And I've just been trying forever and a day. It's been over a year.
Oh,
That's
geez.
my big gripe right there. Also, the guy that's has the for you leaving his white, black, and blue from I sympathize with him 100%. Yeah, and yeah, we're sleeping in separate bedrooms, but we do make time. We schedule, and I'll give it a whirl. Like my track record, I'm working track record ever since we've been in both bedrooms has been I've been able to sleep 2 nights in the same bed with my wife. But I think last night she said I gotta get some sleep and see you later. I said okie dokie, and that was the end of that. But we just try to do it as best we can, and
Yeah.
what can you do,
Yeah. That was my thought too, is if there was a way to at least start off in the same room,
man?
and like cuddle or whatnot, even if it's 10 minutes. And then like you said, kind of, okay, good
Yeah.
night.
Yeah.
Um,
It's
yeah.
amazing how much better you feel when it's done. I didn't realize I just miss being in the same space with her. And
Yeah.
it's just so much better. Uh,
Yeah.
yeah. Didn't realize it was really that bothering me that much until it was taken away and it came back. So
Yeah. Absolutely.
Do we have any other questions? All right. Well, thank you so much for Melissa for the presentation. I think it's very important. I think it's, especially important that you continue to prioritize your relationship with your partner, even as your, dynamics may change. So again, thank you, Melissa. It was a great presentation. I will upload this to YouTube so you can see it again, as well as send out the slides later this week. Just a couple of other announcements. Next week, we have a webinar about neuroplasticity and exercise and the benefits for Parkinson's disease. And then the following Wednesday, we have another webinar about the benefits of exercise for Parkinson's disease. I think there's a pattern. And I did want to let everybody know also that our registration is open for our Care Partner Summit in Charlotte, which is on March 21st. This is an event designed with the care partner in mind. I know last year we did get some feedback that some people could not attend because they could not leave their partner alone for so long. We have arranged caregiving at the Ivy, which is just a few miles away. And there's information about that on our registration page. I'll send it all out if you're interested in that. And then we also have our registration is open for our Charlotte Move It Walk, which is on April 25th, and our Wilmington Move It Walk, which is on May 16th. Those are also on the website, and I'll send those out in our email as well. Again, thank you so much for joining us today, and I hope everybody has a good rest of your day. Bye.